he was diagnosed as migraine and treated as migraine by internal medicine people and with amitriptyline, and he improved. So first time he didn't come to us. So this is all I got it from our OPK sheet. So in December 2019, and he came again, he attended the emergency. Following a minor trivial head injury, he fell from his two-wheeler, but there is no even any scalp abrasions or any injuries. And after 1 or 2 days, he had a history of headache and binocular horizontal diplopia, more on distant, looking at distant objects, with episode of vomiting. And that time, I think he has consulted an emergency medicine department, and they done a CT brain. It was normal. So then, because he had a diplopia, he visited an ophthalmologist, and they attributed the diplopia to the head injury, probably a sixth nerve palsy. And with a few days to a week, I think his headache and diplopia improved. And the treatments what was given to him is not known. So in May 2020, he came to the ophthalmologist again with headache and binocular vertical diplopia. He went to the ophthalmologist because his wife works in as an optometrist in the ophthalmology department. So they have done a diplopia charting, showed a maximum separation in the right photorectus area, and he was not. I don't know why the MRI was not done. The ophthalmologist sent him with some analytics, and I don't know what is the reason. But anyway, that time also he did not visited us, so he improved. In September 2020, he came to us. He had a 1-month headache, and probably not so severe. That is why he didn't come within the onset of the early days of headache. And worsening of acute headache for last 3 days with neck pain and photophobia. And he had a binocular horizontal diplopia, more to the distant vision, and history of ataxia of gait for 1 day. And there is no history of fever, seizure, or weakness. So he had multiple episodes of headaches and terminal palsy. Now this time it's so severe. And examination, GCS was normal and vitals were normal. And but he had a bilateral horizontal jerky and heterogeneous nystagmus on both sides. And he had evidence of right fourth nerve palsy. And he had evidence of left sixth nerve palsy and left seventh nerve palsy, complete seventh nerve palsy, with other cranial nerves are normal. He had normal limb power and sensation, and reflexes are present plantar structure. And he had a severe ataxia of gait, swaying to either side, with a tandem impairment. He had a neck stiffness. He had a positive neck sign, and he had a neck stiffness. So this is the first imaging done with MRI brain, with contrast, MRA, MRV, and MR spectroscopy. This is showing that there is a hyperintense lesion. This is in the FLAIR and T2, in the medullary and pontomedullary junction, and in the pons, as well as in the midbrain, and probably the left side of the thalamus. So this is a lesion which are seen in T2 and FLAIR. Probably most of the brainstem, and in the diffusion there is some areas of diffusion restriction in the pons as well as in the midbrain, and there is areas of hemorrhage in the left side of the pons. And the contrast was for our eyes, I think it looks normal. But reported was as lower midbrain and superior pons hyperintense lesions. Though we couldn't see any lesions, this is like T2 and FLAIR hyperintensity without much of diffusion restriction, suggesting like vasogenic edema, and which is extending into the bilateral superior cerebellar peduncles. And there is a few areas of diffusion restriction and small areas of hemorrhage in the left pons. The radiologist has given us there is heterogeneous enhancement, but for our eye, in ACT eye, I think I couldn't find any enhancement with the subtle ring enhancement lesions. And a spectroscopy, they given us elevated lipid lactate peak with preserved choline, and MRA and MRV was normal. So the things considered was acute infections, because he had a neck stiffness, photophobia, though there is no history of any fever. So we thought of any acute infection. meningoencephalitis, or some granulomatous lesions like tuberculosis, or some neoplasm. This is our initial diagnosis. So I just want to stop this, and I just want to ask about what maybe my teachers think about this patient's presentation and the possible differential diagnosis other than what I have maybe put up.
Can I see the previous slide, Balkishan?
Sir?
The differential diagnosis. Okay.
Yes, sir.
Sir, can I, sir?
Yes, sir. Please, sir.
Sir, yes, sir. Can I?
Yes, sir. Sir, shall I proceed or?
Again, sir, you have to unmute yourselves.
Yes, Meenakshi. You want to say something on this at this stage as
Yes,
a teacher?
Yes, clinical syndrome is one of recurrent brainstem involvement, predominantly in the pons and the lip brain. And it has been like
UMS can't hear you. What did you say first?
the recurrent brainstem involvement, I said.
Yeah, you said
Yes,
something. You said some syndrome.
No, sir, I didn't say any syndrome.
Okay, thank you.
He said brainstem syndrome.
Recurrent brainstem, the clinical syndrome, I said. The clinical syndrome is one of recurrent brainstem involvement.
Left side or right side?
He said, I think it is left side predominantly, but he said something about right fourth nerve palsy when he presented. On the slide said left fourth nerve.
Yes, sir. Yes, sir.
So I suspect it's on both sides. So in a presentation where there is predominant involvement and it is self-limiting also, it is every time recovered to. The whole history is only about 1.5 years now. I'll be very looking at that MRI too. I'll be very tempted to think about clippers as a diagnosis. And
Sorry, UMS couldn't hear you.
Clippers, sir.
Yeah, that's what I written in the chat box. Clippers.
Sir.
Yeah,
clippers.
That's my impression.
Other differential would be whenever there is a headache and involvement of cranial nerves, and when it involves a midbrain predominantly, Behçet would always come into the picture.
What about the headache? What about the headache? He had headaches right from the beginning.
Yes, sir.
Yes, sir.
You got to fit in that also, no, clinically?
So with inflammatory disease, it can happen, sir.
I know, because beginning itself, that was not remitting, was it? Headache?
Remitting, sir. Remitting with treatment.
Vomiting?
Subsequently, sir. Later.
What treatment?
Initially,
actually, yes, sir. So actually, the first when he had a headache in 2019, it was typical like migraine like headache, sir. And that time he didn't have any cranial nerve palsies, but subsequently he had 2 episodes of headache with the cranial nerve palsies. Though he was not present to us, he was seen by ophthalmologists and internal medicine people. So I just checked the prescriptions. It's all containing only some paracetamol and some
No steroids.
Not steroids, sir. Not steroids. Not steroids. That's what I think is very intriguing, sir. Anyway,
looks like clippers only to me also.
Sorry?
Clippers to me also.
Can you?
Vijayan.
Who is this, please? Who is this, please?
Sir, Vijayan, sir.
Okay, Vijayan. Thanks.
Looks like clippers to me also.
Yes, sir. Yes, sir.
The image looks very typical of the clippers. And regarding the prolonged history, spontaneous remissions, probably it's definitely not, very unlikely to be a neoplasm. If at all a neoplasm should be a lymphoma. Very unlikely, very unlikely, but still because of the spontaneous remissions over such a long period. Again, TB granuloma, it's a possibility, but again, such a long duration, spontaneous remissions, again, very unlikely, but still will be in the differential diagnosis. Looks like a chronic relapsing remitting inflammatory lesion, peripontine brainstem involvement, looks clippers to me.
Much lower
Yes,
down
sir.
will probably be a brainstem glioma also. Much lower down, much lower.
I didn't
Okay.
get the remission part in the history.
Yes, sir.
Balakrishnan,
Yes, sir.
the remission part in the history I missed.
Yes, sir. There is definite relapse and remission, sir,
Right.
before this presentation. Shall I
Sir,
proceed, sir?
now, sir,
Yes,
sir, just to recap, Bala, 1 minute. Sir, Professor
Could be
GA, sir,
sarcoid also. I mean, sarcoid also one of the functions.
sir,
Yes,
Professor
I
GA, sir,
put
just
it
to
in the next.
recap,
Yes, Natarajan.
sir, November 2019, he had episodic headache which responded to amitriptyline. Then in December 29, 1 month later, he had a head injury, trivial, at which time he had diplopia and headache, had CT brain done, which was normal, and then again responded, both diplopia and the headache subsided. Thereafter, 5 months later, in May 20, he had vertical diplopia again. I do not know what happened to the diplopia after that, but 4 months later, he had headache, and this is the time when he had meningeal symptoms as well as diplopia and severe gait attacks. And at this time on examination, he was found to have 4th, 6th, and 7th nerve paralysis on the left side with ataxia and nystagmus.
I
This
was
is the
looking
clinical.
at time frame of recovery. How long it took to recover every time?
That we don't know, sir, because the patient had not been attending at PSG. According to him, Bala, maybe you can contribute more.
No, sir, actually, they were visiting ophthalmologists and the medicine people. Only when he had developed a severe facial palsy, multiple cranial palsy, they just visited us. Before that, it was managed by medicine department. So the time frame exactly was not mentioned in the case sheet, sir. That's why. So I'm not able to say, but each time probably within a week or 10 days he recovered. Sir.
What was his occupation, Bala?
He was an actually, sir, he's a clerk in the office.
Did he go
He's a clerk in.
Bala, you will have to consider listeria also.
Listeria would be more middle line.
Yes,
Pardon?
sir. Definitely. Yes, sir.
And
Listeria.
also would be the DD.
Middle line.
Yes, sir.
Bala, did he go trekking or anything?
No, sir. No, sir. He's very well stays inside Coimbatore.
Lyme's disease will have to be.
Lyme's disease, yeah.
Okay, go ahead, Bala.
Yes, sir. So this is what we thought: sarcoid lymphoma, Behçet, and infections. And we started doing investigation. ESR was high, hemoglobin was low, and CSF showed 510 cells and predominant lymphocytes, and macrophages 43, and protein was mildly elevated. Sugar was normal, and ADA was normal. No malignant cells. Gene expert, gram stain, AB staining, all this panel are negative. So anyway, we did a ANA profile, ANCA profile, ANA IF, APLA, NMO, MOG, AZ levels, all negative. So we were started on empirical ATT and steroids, and probably within a week he had a dramatic improvement in cranial palsies and ataxia. ATT was continued. 3 months follow, he was completely normal, no cranial palsies. We repeated an MRI. MRI was absolutely normal. Anyway, I didn't put it, but anyway, he has 4 MRIs. So MRI was totally normal. But again, in February 2021, we tapered steroids. It was on only ATT. He came with 1 week of global headache, no other neurological symptom. And this MRI done showed there is a pontine lesion on the left side, no enhancement, but this white matter hyperintensity was seen even in the first MRI. So this is a new lesion, and steroid was added to the regime, and I was continued on ATT. Again in April 2021, he had binocular vertical diplopia, and he had a skew deviation, and he had evidence of left superior rectus palsy. And this time, MRI was done, showed there is a pontomedullary junction lesion. The spontaneous lesion has disappeared. and the white matter lesions were normally, as usual, seen. There is no enhancement. Now diagnosis.
Clippers, sir.
Okay, sir. No, sir. There is a lot of twist in this. Anyway, I'll.
What was the CSF? CSF, you said, what was the CSF like?
Sir, it was 510 cells, sir.
And why so much of macrophages?
I don't know, sir.
Smear.
Sir, smear, no malignancy. The peripheral smear was normal, sir. There is no malignancy in the blood, sir.
Much macro peripheral smear.
The peripheral blood was normal. So each time, so whenever we send for a complete hemogram, they look for a smear and they look for any malignant cells, even without be asking for it, because it's a routine in our pathology department.
I think all
Was the
we
chest
have.
CT done? Was the chest CT done?
No, sir. X-ray chest only done, and we didn't do any CT chest.
CSF AC levels.
AC levels were normal, sir. AC
CSF.
levels were CSF AC levels I didn't do, sir. It's only serum AC levels we did.
What about NMO?
NMO is negative, sir. NMO MOG is negative.
I think all we have is to now look at the syndrome with the investigations. I think we're looking at differential diagnosis for lymphocytic
Meningitis. Chronic lymphocytic meningitis. Adana, sir.
Lymphocytic meningitis. So if we talk about lymphocytic meningitis, apart from yes, Lyme disease, of course, tuberculosis.
Bala, was the CSF done only once?
Sir, CSF done only once, sir. I'll tell you why we are not
That
repeating.
was in September 20.
Yes, sir. I'll tell you why it is not repeated, sir. I'll tell you after this is over.
Okay, okay.
So the HIV status?
HIV is negative, sir. HIV VDRL we are done, it's negative.
The patient COVID positive?
No, sir. No, sir. Each admission we do a COVID, sir. It's all negative.
Why didn't you do a CSF, sir?
I'll tell you, sir.
பயங்கரமான suspense ஆ இருக்கு.
இல்ல sir, I know. If I tell, I'll put few slides. I think you know the diagnosis anyway. That's why I'm just hiding few things which are done even after the first admission.
Very good. Very good.
Because I want to create some interest. That's why I didn't show the few investigations done in the first admission, which made us some different diagnosis, but I have not put it in the this thing because I want to create some interest.
Okay, sir.
So, shall I go over, sir?
Please.
Yeah.
Yes, please.
Yes, sir. And we had a process of recurrent total.
Our Behçet's disease.
Yes, sir. No history of any skin lesions, and there is no history of arthritis. And this is done in even September 9, 2020. This is actually B51 is positive.
Sir, ophthalmologist would have done it, le?
Yes, sir. No, sir. No. I'll tell you, sir. This patient, after the first admission, they gone to CMC Vellore. After just 10 days after this thing, they gone to Vellore, and they didn't even give us time to maybe analyze what it is. So there they have asked for a HLA-B51, and it was positive. And our rheumatologist done a pathology test. It was positive. And this is the ulcer, and probably the February admission. They are typical punctuate oral ulcers. And he had a previous history of recurrent oral ulcers and scrotal ulcers. We could see the scarring in the scrotum. So,
sir, இந்த போட்டோ நீங்க முதல்லயே போட்டுறணும்.
Yes, sir. அது போட்டு தான் diagnose
அப்ப இன்ட்ரெஸ்டே இல்லையே.
அது இன்ட்ரெஸ்டே இல்ல சார்.
நல்லா இருக்கு. சூப்பர்.
Excellent. Excellent.
Sir.
Super.
Sir, no, I have few doubts, sir. Whether there is any associated any infection,
It's
sir.
called teaching presentation.
Sir?
It's called teaching presentation.
Yes, sir.
Like a teacher.
Yes, sir. So
Bala,
I
you
had
have
only,
doubts?
yes, sir. So the 510 cells is very, very high for any neurobacterial disease. I referred, sir. And even CMC, I spoke to the Vellore people. They told don't stop ATT because the cell count is little unusual for neurobacterial. That's why I think we continued for 9 months. So I'll tell you what has happened is, so diagnosis was confirmed after the first admission, first consultation, but I didn't want to put everything because I just want to create some interest. What is the cause of recurrent cranial palsy, brainstem syndrome? So ATD was continued in view of disproportionate CSF pleocytosis. So steroid, IV steroid was given for 5 days, followed by oral steroids after the first admission. So after the first relapse, I think Azuran was added. So he had a second relapse after 100 milligrams of Azuran plus he was on oral steroids. So injection cyclophosphamide was given first cycle. So we are giving a second cycle this month. So in a summary, I think is a young male. Initial presentation is typical like migraine-like headaches and episodic headache and diplopia, brainstem syndrome, and which is relapse and remitting, and acute brainstem syndrome with CSF pleocytosis, and past history of recurrent sclerotal ulcers and oral ulcers, and HLA-B51 positive and positive pathology test, and I had a very good response to steroids and the relapse on steroids and azathioprine, and he was given cyclophosphamide because he had a relapse on Azuran. So this is neurobacterial disease. Probably I have seen only few cases of neurobacterial disease. One case presented with multiple lower cranial palsies. Another patient, one patient who had a CVT. So this is only 3 patients probably I have seen in my probably 10 years of career. I think
More than mine.
all, sir?
More than me anyway.
Sir, so I think you all might have seen more than maybe whatever I am. This is very, very, very interesting for me because the initial presentation was like relapse remitting. That is very typical like demyelination or some is what I thought. So I just want comments and probably opinions and this management options regarding for this patient.
Anybody else want to come in? Anyone to come in with their experience?
Sir, I had, in fact, one of the differential diagnosis was Behçet when he presented. And the point is the involvement of the midbrain, especially, and that's pointer towards Behçet. When he presented, I was about to ask him about HLA-B51. But because he said ANA negative, I wanted to specifically ask, and it's a good point. But Behçet is known to present more with what appears to be brainstem infarcts. They look like they have had recurrent brainstem strokes. That's what I have seen. The couple of cases at least I have seen. I have not seen too many. And this is a very good presentation. Thank you, Balakrishnan.
So shall I have some 4 or 5 slides about the Behçet, or we'll just stop with this?
No, please go ahead.
Please go ahead.
Please go ahead.
So, and this is a challenging diagnosis, sir. I think all of us understand. And we need to rule out other neurological conditions that may have present a similar presentation. The closest differential diagnosis are like any brainstem syndrome, we'll think about multiple sclerosis or neuromyelitis optica spectrum disorders and CNS infections and neurosarcoidosis and CNS vasculitis and primary CNS lymphoma. So this is all closest differential diagnosis, and usually occurs in around 5 to 10% of patients with Behçet's disease. Usually occurs within 5 years after the onset of disease and more frequent in men. Though other degenerative disease more commonly occurs in MS and occurs more commonly in females. And recurrent clinical presentation with relapse and remittent phases are classical presentation of neurobacterial, and sometimes even can progressive course like primary progressive MS. There is both central nervous system and peripheral nervous system are affected. The peripheral nervous system affection is very rare, and central nervous system is parenchymal and non-parenchymal. And brainstem syndrome is the most common syndrome in parenchymal. Non-parenchymal is venous sinus thrombosis. So there is 4 syndromes, 4 most commonly affected areas. Most common is brainstem. As VMS are told, midbrain and pons is the most common area involved. They can present with recurrent ophthalmoparesis, dysphagia, cerebellar symptoms, and pyramidal involvement. And they can have diffuse or multifocal presentation. And they can have a combination of cerebellum, pyramidal, brainstem, and spinal cord signs in a single patient. And they can have stroke-like presentation, like hemispheric involvement, like hemiparesis, aphasia, cortical visual loss, agnosia, and they can have tumefactive presentation. So there can have, I think if you don't have any other diagnosis, we have to suspect neurovectures. And myelopathy is also common. It's one of the closest to DD for LETM. The most common area involved is cervical thoracic region, like typical of NMO. And they can also present with optic neuropathy and psychiatric symptoms. And non-parenchymal venous sinus thrombosis is the most common presentation. They can have arterial vasculitis also. They can have aneurysms in intracranial and extracranial vessels. And they can have dissections and MC occlusions. As Sir told, most common is midbrain and mesodiencephalic junction. Like what they say is the brainstem lesion extending
Most
into the
typical.
thalamus.
Correct.
Yes, sir. Yes, sir. Most typical. And whether it extends into the basal ganglia is very typical. As I told you, spinal cord, it can have presentation like LETM or maybe short segment demyelination, can mimic like MS and NMO spectrum disorders, and can come with acute stroke. That also can have this thing. And because of the basal ganglia involvement, they can have chorea or Parkinsonism. That also has been described in patients with Behçet. And venous sinus thrombosis is the most common. And whenever you have unexplained arterial dissections and unexplained aneurysms, we have to suspect neurovecture. I think this is very important. And this is the study shows areas of involvement in around 68 patients of neurovecture. And lesions are mostly this non-enhancing. So that is this thing. So most common is mesodiencephalic junction is the most common area involved. And lumbar puncture, coming to the lumbar puncture in neurovecture, it's abnormal in 70 to 80%. There is a parenchymal involvement and high opening pressure and high protein, usually normal glucose. So high lymphocytosis, OCB absent, and maybe normal in non-parenchymal neurovecture. Genetic factors HLA-B51 and B5, and pathology test is positive. No diagnostic criteria, and so any patient who was clinically diagnosed as Behçet coming with neurological manifestation, we know that this is neurovecture. But if the patient first time coming with only neurological symptoms, and we have to always rule out all other different closest differential diagnosis by imaging and laboratory investigation. And this is a criteria. I think we all can go through this. And treatment, there is no control trials. Acute neurovecture, like any other demyelination, gradual tapering for over 3 to 6 months of oral steroids. And they have very good results in brainstem lesions and parenchymal forms. Long-term immunosuppressions can be tried like azathioprine, citalopram, cycloserine. And biologicals, monoclonals can be tried. And even cyclophosphamide has a very good response in patients with neurovecture. Thank you, sir. That's all from my side, sir. Thank you. Sir, I think you all have to unmute, sir. Sir, Ryan, sir.
Why
did
not
he
rituximab?
Did he also have uveitis?
No, sir, he didn't have any eye findings, but I don't know whether we didn't go and retrospectively ask whether he had any uveitis, which is maybe self-resolved. Probably when he comes next time, I think I'll ask him about uveitis. But I went through the whole case sheet OP file, and there is no, I think he has visited multiple times to the ophthalmologist, but there is no evidence of any uveitis.
Did he have MR venogram?
Yes, sir. MRV was normal. MRA is completely normal.
Okay, thank you.
Many years ago, I went to Kuwait. Riaz was there. He invited me there. And they showed me at least 3 cases of that in a discussion. They seem to have a higher incidence there of neuroBehçet than anywhere else. I don't know the reason. I don't know the epidemiology. I saw 3 cases in one day.
From Vellore, again, they have published a series of neuro-Behçet cases, sir. I'm not sure the number, 11 or 16. Our Dr. Girija, who was our postgraduate, and now the professor, she was a visiting professor at CMC. She had gathered all these cases together and published it, sir. Neuro-Behçet.
Somebody can give us a reference? Girija?
I can get Girija. Should last session she attended. I just looked for her. She is not there. I'll get her, sir.
Get a reference from her and distribute to us, no?
Yes, sir.
I never read so much of neuro-Behçet. Oh, this is about 10 years ago when I went there. They produced 3 cases in one sitting. And Riaz told me it's quite common there. Good, thank you so much, Balakrishna.
Turkey side, sir, particularly in Turkey, around that region, sir. Turkey.
Middle East,
That's the center for Behçet, sir.
Peculiar susceptibility, I think the gene. Thank you, Balakrishnan.
Yes, sir. Welcome, sir.
Presented like a teacher.
Yes, sir.
Thank you, Bala.
Sir. Thank you, sir. Thank you, sir. Thank you.
Who's next?
Thank you, sir.
The next will be Dr. Ramakrishnan from KG Hospital, sir.
Oh,
He is
great.
the head of the neurology department. He is a pediatrician and then neurologist trained at our institute, sir.
Oh, great.
An outstanding student, sir.
He looks very handsome.
He is, sir.
Where is he? Is he not visible?
He is with his family there.
Where?
No, sir. No, sir. I'm opening the presentation, sir.
Okay, Raja.
So is it visible, sir?
Very
Yes.
visible.
But
This
you'll have to magnify.
This is a place where I have gone so many times. How's Dr. Bhaktavatslam?
He's doing well, sir.
Is he's all right?
Yes, sir. He's all right, sir.
But he didn't respond. I tried to call him and send a message. So I was a bit worried.
Sir, I will ask him to call you, sir. Yes, sir.
Give my blessings to him.
Yes, sir. Thank you, sir.
One of the very active private.
Yes, sir.
Great interested in neurology.
Yes, sir. Yes, sir.
Okay, Raja, go ahead.
Yes, sir. Thank you, sir. At the outset, I thank Professor VN, sir, and Dr. Arjunda, sir, for giving me this opportunity. 1 second, sir. It's not moving. Yes, sir.
But we haven't seen you. Where are you?
So I think I have to 1 second, sir.
Not taken a selfie?
I have to. I don't know how to do it.
Meenakshi is an expert.
Not your video, Ramakrishnan.
Yeah, turn it
yes,
on. Quite simple.
yes, I have done it, sir. I have done it, sir.
You still got neurometabolic disorder. We
Yes.
haven't got.
So these are a little different from what Balakrishnan has presented, sir.
That is your photo.
I got you. Saw you.
Yeah.
We saw you, I said.
Okay.
Yes, sir. Yes, sir. Yes, sir. I thank VN sir for this wonderful opportunity, for giving us an opportunity to present these cases, sir. Thank you. I thank Sunpharma for this opportunity. I am going to present 3 cases, which is little different from what we usually see in our adult neurology practice, sir. This is a 6-month-old girl who presented to me at 6 months of age. She was first born to non-consanguineous parents with normal antenatal history. She was delivered normally. The perinatal event history was normal, sir. She cried immediately after birth. She was normal up to 4 months of age. She had normal development up to 4 months of age. After that, parents noticed that she has lost whatever milestones she has acquired in the first 4 months, sir. She has lost his social smile. She was seeing his fingers and playing with his fingers at that time, which she has lost. And they have noticed exaggerated startled response since 2 months of age. Along with that, they have also noted that she has got episodes of vacant stare lasting for 1 to 2 minutes without motor activity. The episodes were multiple per day. They haven't noticed any twisting movements. They haven't noticed any episodes of inconsolable cry with abnormal posturing of limbs. There is no skin lesions. There is no specific odor felt in the urine or sweat. There is no previous miscarriage. The family history was, there was nothing, there is no family history of early deaths or developmental delay or intractable epilepsy, sir. So on examination, she was awake, alert. She was focusing. There was no dysmorphism. She didn't have any neurocutaneous markers. Her hepatosplenomegaly. Her tone was normal. Her AF was normal, and her head circumference was 43 centimeters, which was within the normal range for her age. That is, there is no microcephaly or macrocephaly. So provisionally, generally we will consider in these kind of children, because the child was apparently normal till 4 months of age. Following the onset of seizures, there is regression of milestones. So the child has got two problems: seizures, regression of milestones. So we'll consider generally these kind of children will come under the group as early infantile epileptic encephalopathy, sir. Early infantile epileptic encephalopathy means there's epileptic discharges which contribute to progressive psychomotor dysfunction. It usually starts at an early age. The seizures will be multifocal and intractable. They'll have different kind of seizures. It will be associated with cognitive, behavioral, and neurological deficits, and they generally have a poor prognosis, especially some syndromes. But there could be some etiologies which may be treatable. So generally, how we go about is generally we consider the possibility of something treatable conditions like pyridoxine pathway defects, where pyridoxine will help them, or sometimes biotin defects where biotinidase deficiency is there, or some aminoacidopathies, organic acidemias, urea cycle defects, all those things, and genetic conditions. So what I did in this child is, sir, how we do is, first we will do an MRI brain with MR spectroscopy. Then basic metabolic workup we will do in the setup where we have, and probably for further studies we will refer them to genetic labs, metabolic lab. So basic test, generally we do this basic workup, and uric acid generally we do. Generally, what we expect is to have a low uric acid in case of molybdenum cofactor deficiency and succinic semialdehyde dehydrogenase deficiencies. And we will do prolactin to look for CNS CNS neurotransmitter disorders, ABGA to look for acidosis, and ammonia and lactate we all know to look for mitochondrial disorders or congenital lactic acidosis and organic acidemias. So homocysteine and B12 to look for B12 defects. CSF, especially we focus on sugar, because CSF sugar when compared to blood sugar will be low in GLUT1 transporter defect. So that will be a clue to diagnose GLUT1 transporter defect where the treatment is different. So, and finally genetic testing. So what I have done for this child is we have done the basic blood workup which was normal, and serum ammonia lactate and pyruvate was normal, serum uric acid was normal, serum prolactin was normal, ABGA was normal, MRI brain was normal. There is no structural abnormality was seen in this child, and EEG it showed multifocal abnormalities on both sides, which is suggestive of symptomatic generalized epilepsy. It has multifocal spikes and also generalized paroxysmal fast activity was there. And we referred for a pediatric ophthalmic opinion where they have seen there is no ocular fixation, and optokinetic nystagmus was also not there, and there is no cherry red spot was there, because the child had exaggerated startled response. We want to look for cherry red spots. So and we further proceeded with neurometabolic workup, and meanwhile, because these tests will take time to come, it will take two weeks, then we can't wait for the time. So empirically for seizures, we have started her on levetiracetam, and most of the time we will consider if they are not responding to medication, pyridoxine pathway defects. So pyridoxine we will start at the dose of 20 to 30 milligram per kg per day. And if you are not sure, probably folinic acid also, because there is one group of conditions where folinic acid they will respond. Despite that, she didn't have any, the seizures continued, the developmental regression also persisted despite these treatments. So we also added pyridoxal phosphate, but that doesn't work for in her favor. So then they came this metabolic work report that which showed that CSF amino acids was significantly low serine level was detected. So it is in favor of the diagnosis of serine synthesis defect, which is an amino acid disorder. It comes under amino acid synthesis defects. And along with it, CSF methyl tetrahydrofolate was also level, which will be low in these conditions. So provisionally, we thought of the possibility of serine synthesis defect and started her on serine. Thanks to the Amazon, the parents could get it through Amazon, where we started her on serine at the dose of 500 milligram per kg per day. Actually, the treatment is to start her on serine and glycine also. But glycine, after starting on glycine, she developed loose stools and vomiting. She couldn't tolerate. So we continued her with serine. Seizures got better. Meanwhile, I have sent the sample for genetic testing also for clinical exam. So the clinical exam result came as Aicardi-Gottlieb syndrome. So I would like to have the opinion of the seniors, where when we have a clinically like this, and the genetic test is entirely different from what we clinically expect. So what we do, what we shall do at this point of time, sir? Sir?
Yes, please. Somebody wants to come in? Any pediatricians in this group?
Yeah, what was the MRI diagnosis?
The MRI was normal, sir.
MRI was normal. Okay.
This is the MRI report, sir. It's normal, sir.
Can we enlarge the screen? MRI screen. Is it possible?
I do.
Make it the main screen. It's too small to read. Whole slide can be enlarged?
Yes,
No?
sir. Is it seen? Is it visible, sir?
Just about. Bit old for this. Cervical problem, No.
Genetic study was what did you say? It's Aicardi?
Essentially normal.
AGS, sir. Aicardi-Gottlieb syndrome, sir.
What about the fundus? Any cherry red spot?
No cherry red spot, sir.
Ram, in
Sir?
AGS, don't you get abnormalities on the MRI? Can
Yes, sir.
can AGS occur without MRI abnormalities?
So it's very rare, sir. That is what clinically it didn't fit in with the AGS, sir, because AGS is generally called a pseudo-torch syndrome, sir, where they will have calcifications, they will have microcephaly, and the child will have hepatosplenomegaly also sometimes, but not always. So MRI will be entirely different in AGS, sir.
So that is the reason we ask for CT also along with this. Sometimes
yes,
because calcification, yeah. Because it looks more torch than anything else then.
So,
and all those things, they are incidental, or is it associated with that? Serine deficiency, glycine deficiency, all those things, sir. What do they point?
Sir?
Anyone else? Pediatrician? Anyone else wants to comment? Very interesting. Very interesting. Yeah.
What is the occurrence, Ram? How often do you get serine deficiency, and what was the response to treatment?
So for treatment, she responded very well. She responded very well to treatment. Her development has picked up. Seizures has stopped, sir. So we have stopped the anticonvulsants. For this genetic report, what we did is we sequenced the parents. We got the exome sequencing of parents also, sir. For both the parents, it was negative. So we thought it is, since it was an uncertain significance, and clinically also it didn't fit in as AGS. So I didn't give much importance to the report of this clinical exam result, because the parents were negative and clinically it didn't fit in with the clinical diagnosis.
No siblings?
Now she has got a younger siblings who is doing well, sir. No seizures, developmentally normal child. So what I did is we did the exam sequencing for the parent, which was negative. So finally we concluded our final diagnosis is serine synthesis defects. So serine synthesis defect, we treated her with serine and she improved well. The seizures got better and the development also has improved. A few words about serine synthesis defect. It's a disorder of amino acid synthesis. Normally the defects are reported are serine in glutamine, proline, and asparagine. Generally, we diagnose inborn errors of metabolism by finding an elevated metabolite. But here it is the low metabolite which helps in the diagnosis. And there are many forms. Here, if it is seen in the infantile form, it is very the slide is very
crowded.
crowded, sir. But here they can respond very well to treatment if diagnosed early, especially if there are milder forms. So probably I think she has got a mild form of the disease where she has responded to treatment, sir. So the next case, sir. This is the case 2. It's the first of the twin who was born of non-consanguineous birth. Antenatal period was uneventful. The child was delivered by cesarean section. Birth weight was 1.8 kg. They had a normal neonatal period. The child presented at 4 months of age with recurrent episodes of crying, with posturing of limbs and upward gaze lasting for 1 to 2 minutes. The events are increasing in severity and frequency since the onset, sir. And also he has got occasional episodes of vacant stare with reduced motor activity lasting for few minutes. The child has got global developmental delay, hasn't attained any of the milestones. There is no significant family history. The second twin also has got similar features, but of lesser intensity than when compared to the first twin, sir. So on examination, I got the videos, sir, which I will show later. And the child was not focusing or following. There is no menace reflex. There is no cherry red spot or optic atrophy. The child is not turning to sound. The child had brisk reflexes, but tone was variable, sir. So this is the video.
Was this paroxysmal?
Yes, sir. Paroxysmal, sir. Absent during sleep, sir. So this is another video, sir.
I think it should put video in the middle. Remove all the other writing, Zomato, Billy, and all that. What are those things on the screen? There's something else on the screen here.
Yes, I haven't written anything, sir.
No, on my screen I got Zomato, Mike, something. How do I remove this? Wait, let me see.
I have not written anything, sir.
No, not you. I mean, somebody else is imposing. So our screen has become small. I'm just wondering what to do. 1 minute, let me see. I got an arrow here.
So this is the video of the second twins, sir.
Yeah, oh, that's beautiful. Yeah.
So so clinically, because of these episodes, one is the third video. I think it's more likely to be due to seizures because the child has got nystagmus and lip smacking movements, and the other ones are dystonia, which was paroxysmal. The first one, it also had oculogyric crisis along with the upward deviation of eyeball. The child had dystonic posturing, and these were intermittent, absent during sleeps. So in these children, generally who has got oculogyric crisis and dystonia, our first possibility will be CNS neurotransmitter disorders. So the other thing could be a mitochondrial disorder. Congenital disorder of glycosylation is very unlikely because they usually have other organ involvement and they will have dysmorphism. So we proceeded with the evaluation. The biochemistry was normal, sir. Serum ammonia lactate pyruvate was normal. Serum prolactin is actually, we use it as a screening test for CNS neurotransmitter disorder, which was normal. Uric acid was also normal. There is no acidosis. The MRI, actually MRI, they reported it as small hyperintense in the medial aspect of lentiform nuclei. They couldn't say what was the reason for that. One of the possibilities the radiologist thought was it could be due to May loss, which I really don't think could be the reason. The other thing is it could be due to organic acidurias, but the radiologist's opinion is they couldn't come to a conclusion with the imaging what it was. So EEG it showed multifocal epilepsy of bihemispherical origin, left more than right, sir. And I started her on levetiracetam. and considering the possibility of CNS neurotransmitter disorder, started with the child on Syndopa also. After starting on these drugs, there was some 20 to 30% improvement, but the child continued to have these movements. And this is the report of the metabolic report which we got. It is low in 5-methyl tetrahydrofolate level was low when compared to normal children. So it is the case of cerebral folate deficiency, or otherwise we call it as folinic acid responsive seizures. Actually, folinic acid responsive seizures we will treat with folinic acid. Commonly we have got the brand is leucovorin. The dose is 0.5 to 1 milligram per kg per day. Even though, but we have to confirm with genetic testing, which we have sent, and the results are awaited. Sir. Now, the provisional or now possibly the most likely diagnosis is cerebral folate deficiency or folinic acid response seizures. They have varied neurological manifestations. Not all of them will respond to folinic acid. But if you are going to treat them with folic acid, it might worsen the condition. So we should treat them with folinic acid rather than with folic acid. It could be due to autoimmune or due to gene defect. Autoimmune, they'll have onset similar to this child at 4 months of age, which all the manifestations like seizures, dyskinesia, ataxia, and progressive microcephaly. I tried to do this onto antibody to folate, but I couldn't find any lab where they are doing here in our part of the country, sir. So, but because of the presence of involvement of the second child also, I was thinking of the possibility of this FOL1R gene mutation. If we have started the treatment, there is the partial response to treatment. There is no complete response to treatment, sir.
What happened to the mutation study?
Sir, that the results are awaited, sir. Because of this COVID and all, the results has got delayed, sir. So I haven't yet got the results, sir. So third case, shall I proceed, sir?
Now, why did you say it is not mitochondria?
Sir, except for this, the MRI doesn't have any evidence, sir, because what the report has been given as this MELAS, which generally the MRI picture will be different. So it will have infarcts in the usually in the posterior, like a PCA territory infarct. It may not have a vascular territory involvement, and there is no other organ involvement. The basic
very classical basal ganglia involvement.
No basal ganglia involvement. Okay, so only this caudate on one side was there. Lentiform nucleus on one side was there. It is not symmetrical, so it's asymmetrical.
Because we have seen more cases of mitochondria like this than folinic acid. Folinic acid deficiency producing a severe picture like this. I still feel you have done pyruvate lactate levels.
Yes, sir. Serum lactate I have done, sir, which is normal. In this metabolic workup, we have done lactate, pyruvate, all those things are normal, sir.
Okay.
I saw Professor Lima Paul in there.
As this photos, madam is not this photo only. Okay.
Oh, you have projected the photo. Sir, GA sir, can you proceed or anything else, sir?
Yes, I think very interesting. Learned a lot. Dr. Paul is online. She would like to comment, please, Dr. Paul.
I believe she's not there, sir. I believe it was a photo projected by Ramakrishna.
Oh, okay.
Sir, this is the final case, sir.
Thank you very much.
Sir, can I come in, Vijayan? 1 minute. Vijayan.
Yes, sir. Yes, sir.
Hey. Most of the times I don't comment on this because this is choice the only thing is regarding mitochondrial, usually they are not strokes. They are rather called stroke-like episodes.
Yes, sir. Yes, sir.
Please, can somebody
these are
mute?
stroke-like episodes, and they don't respect vascular territory.
Yes, sir. Yes,
and
sir.
it is more because of metabolic failure that they produce ischemia, hypoxia, and ischemia rather than in a vascular territory. That is the only thing which I can comment.
Yes, sir. Yes, sir. You're absolutely correct, sir.
Excellent, excellent. But we didn't see people like me, very old. I want to see people, right? Where is Vijayan?
Sir, I'm here, sir.
I can't see you.
Sir, can you see me now, sir?
Your
No,
video, your
I can
no.
see your
Ah,
name.
sir, I am here, sir. Can you see me,
Yes,
sir?
yes.
Yes, sir. Yes, sir.
Need your
Thank you.
blessings.
Comment. Thank you so much.
Thank
Shall
you,
we
sir.
proceed further?
Yes, sir.
Excellent, Ramakrishnan. Excellent.
The 5 months old child, sir, who's a third born, who's a precious baby. He presented us with the history of recurrent seizures since 1.5 months of age. The seizure semiology was suggestive of flexor spasms and multifocal clonic seizures. Sir. Before seizures, the child development was normal, but after the onset of seizure, the child has lost whatever milestone the child has attained. Antenatal period was uneventful. There is no birth asphyxia. There is no significant family history. When I saw the child, he was in altered sensorium. There is no response to Meniere's reflex. Fundus showed bilateral optic atrophy. The child had sparse fine hair. There is no hepatosplenomegaly or no focal deficit was there, sir. So this is the picture of the child, and we can see the hair is very sparse. I think many of us will be able to pick up the diagnosis, and the child has got a coarse faces. This is the
Minky hair syndrome, sir.
sir.
Minky hair.
Minky hair syndrome.
Yes, sir. One of the differential is Menkes syndrome, sir.
Frontal
So,
bossing, no.
sir.
No, I was just saying frontal bossing.
Yes, sir. So the core features the child hair was hypopigmented hair. This is lactic acid from the investigations, early infantile epilepsy and encephalopathy, sir. So the possibilities which generally we will consider in such a presentation is, one is Menkes syndrome, as sir mentioned, biotinidase deficiency, and a mitochondrial disorder. So the investigations, what we have done, the ammonia was normal, so it was 57. The lactate was high, it is 85. And other investigations are normal, sir. So we did the hair examination to look for Menkes syndrome, which was normal. MRI didn't show any features of Menkes syndrome, where they will have dilated tortuous vessels and cerebral atrophy and multifocal infarcts may be there. So this child's MRI showed mild diffuse cerebral atrophy with thinning of corpus callosum. So we did serum ceruloplasmin level also, which was also normal. So the Menkes syndrome was essentially ruled out. The MRI was not in favor of mitochondrial disorder. The other lab investigations are also not in favor of a mitochondrial disorder. So the two possibilities were either it could be a congenital lactic acidosis, which is also a mitochondrial, basically a mitochondrial pathology related, or a biotinidase deficiency. But the skin manifestations is typical of biotinidase deficiency, sir. So I came to know about this condition with Jayakma's presentation in one of the meetings. So we did a biotinidase level, and the child had very low biotinidase levels, sir. If you see, it is the levels were 1.18, 1.07 only. The normal is 4.5 to 7.5. So what the child has got is a biotinidase deficiency. So these children will respond very well to biotin. So we started him on biotin 20 milligram per day. With after starting of biotin, the seizures got better. Development also improved. It's an autosomal recessive disorder. They usually present in early to middle infancy. Usually they will have hypotonia, developmental delay. The clinical clue is the presence of skin manifestations, including atopic or seborrheic dermatitis, alopecia, hypopigmentation of skins. So this kind of skin manifestation with encephalopathy, usually the diagnosis is more likely to be biotinidase deficiency. They will respond very well to biotin, but their hearing and visual impairment will not improve. The child continue to have hearing loss, where we have suggested them to use either hearing aid or go for cochlear implant. But I think cochlear implant may not be possible, so they are using hearing aids. The other one is mainly in diet. We should ask them to avoid egg white, and because the other children also could be affected, we have to screen the first degree relatives. Actually, in the Western world, this comes under the newborn screening program itself, where they will be diagnosing these children before the onset of symptoms, and they could be able to treat them. So they because the child improved well, they stopped the treatment in between. And again, they came back with the recurrence of seizures, following which we started again on biotin, and he's doing well since then, sir. I think that is the end of the presentation, sir. So 3 cases I have presented, sir. Mostly these things when children like this come to neurologist or for us, generally it is we have a nihilistic attitude like that. So what we are going to do? When I came in first, I was called as are you an MRCP doctor? No, sir. What is MRCP means? Mental retardation, cerebral palsy, doctor. So generally we have like this a negative attitude, but there are many conditions which if you are able to diagnose, these are rare, it's not common, but it changes the life of these children and also the parents, and the treatment is not costly. Most of them are vitamins and supportive measures. Thank you, sir.
I can I can relate to this kind of treatment and testing in our days. We couldn't even do amino acidureas in those days. This is where Kumaresan came to us. So much advances have occurred now. Thank you very much. Excellent presentation. Learned
Ram,
a lot.
Sir?
Can we start levetiracetam in children less than 1 year of age?
So more than 4 months, we can start levetiracetam, sir. But off-label use, even in neonatal period, we are using levetiracetam. And there are studies where they have compared the usefulness of levetiracetam versus phenobarbital even in neonatal seizures, sir.
No adverse effects.
No adverse effects, sir. We haven't come across any significant adverse effects, sir. Only thing in the studies shows phenobarbital fares better when compared to levetiracetam, even in HIE children. But adverse effects are not much, sir.
Shall I say anything?
Yes, sir. Yes, sir.
Please, sir, you are supposed to.
Yeah, this is biotinidase deficiency on the first look. Before I start saying, since he said the Menkes, I thought I'd let the discussion go. It is a very classical biotinidase. The moment you see a child with seizure, with hair abnormality, think of biotinidase first more than Menkes kinky hair, because that is very rare. And biotinidase is not rare at all. We have seen several cases now, of course, after the awareness of biotinidase, and they have got families of biotinidase, and mother will, for the second child, will come and tell that kindly give biotin for this child, even before diagnosis. Like that, no, because the improvement they get with biotin is enormous. It is spellbound, because the moment you start, these children become almost normal. I have seen a child in a lift. When I was going up, the mother standing there said, "Good morning, sir. This is a child with biotinidase deficiency, and I've got a second child. I've already started on biotin." And that is how they say. The biotinidase deficiency will give you a very good name also once you diagnose and treat the child. And the biotinidase deficiency is not at all rare. It's quite common. Any neonatal seizure, it should be one of the differential diagnoses. And we have got, I think, following me, my daughter has also diagnosed biotinidase deficiency like that. Like that, the diagnosis can run in families.
Is Lima madam there? Lima Pauline, are you there, please?
Yes, sir. Good morning, sir. Am I audible, sir?
GSR,
Yes,
GSR
yes,
called
madam.
you.
Can you become visible also?
Sir, through audio, sir. I just now logged in, sir. Sir, this is a very excellent case, and kudos to and congrats to Dr. Ramakrishnan. As Meghandan sir has pointed out and commented, any child, especially an infant, whenever the child presents with an afebrile seizures, first of all, we have to look at the hair as the scalp for seborrheic dermatitis as well as for alopecia. Then empirically, we have to start biotin, as Ramakrishnan has pointed out. If the child has developed optic atrophy and hearing loss, it is irreversible. And once we have started biotin, all this lethargy, this seizures, they will have a dramatic response, as well as the skin and the hair findings, they will all revert to normal, and the development will become normal. Once if it is late, then the children will be having residual spastic quadriparesis and all, developmental delay and all. We have treated 4 children with the biotinidase deficiency. 3 of them had a severe deficiency. Severe is defined as less than 10% of the normal enzyme levels, and mild is defined as 10 to 30% of the enzyme levels. And the another point is empirically we have to start biotin, and administration of biotin will not affect the serum biotinase level. So initially we have to, whenever we suspect, immediately we have to start biotin, and then we can proceed for serum biotinase levels. Of course, the TMS can provide us some clue in that the C5-DCOH will be elevated. That is an metabolite of this metabolism. So that can give us a clue, but a confirmed diagnosis will be by the serum biotinase level and then by genetic mutation, that is biotinase gene. That is, sir. And another differential diagnosis is, as he has pointed out, Menke, but as sir has pointed out, it is very rare, and it is Menke is an X-linked recessive disorder in which serum ceruloplasmin will give us a clue. Both serum copper as well as serum ceruloplasmin will be low.
Natarajan,
Yes, sir.
Professor Menke visit us?
Pardon, sir?
Didn't Professor Menke come here to the institute in one of the meetings?
I offhand I can't say, sir. I don't remember, sir.
Yeah.
No, I don't think.
Excellent, Ramakrishna. Excellent.
Thank you, sir. Thank you. Thank you.
One
Lima,
more
madam.
point, sir. One more.
Lima,
Sir,
madam.
one more point, sir. Late. Yes, sir. Yes, sir.
No. I just since you joined late, the previous two
Yes,
cases were folinic acid responsive seizures and serine synthesis deficiency.
Of course, they are very rare, sir. Very rare. And folinic acid, again, if the pyridoxine trial shows partial improvement and partial reduction in the seizures, frequency of seizures, the next step is either we have to add pyridoxal phosphate or folinic acid. Probably Ramakrishnan would have followed that and confirmed then by CSF amino acid profile. Is it so, Ramakrishnan?
Yes, madam. Yes, madam. That's what I have done, madam.
Very nice. Very nice. How about serine deficiency?
Serine deficiency is, madam, I will go back, madam.
We have time.
I want to ask you, all of you can make an algorithm for us to follow in child seizures without fever?
Yes, ma'am. Yes.
Yes, sir. We do have an algorithm and protocol, sir. Once we have an afebrile seizure, first and foremost, we will be ruling out the common metabolic errors like hypocalcemia, hypoglycemia. If they are so, then we will follow the flowchart for them. And then the next thing will be an MRI brain, which will rule out, in which we will be looking for structural anomalies like developmental malformations of the central nervous system, HIE sequelae, then intrauterine infection, neurocutaneous syndromes, and certain inborn errors of metabolisms in which we will have a typical MRI findings like maple syrup urine disease, then our glutaric aciduria, such things we will be ruling out. Once the MRI is normal, then the next step will be, we will be introducing empirical pyridoxine trial, 30 milligram per kg per day, oral trial, since we do not have any IV preparation here in our setup. So oral trial 30 milligram per kg per day for 3 days. If there is a dramatic response in seizures, that is no more seizures, then we will consider it as an pyridoxine dependency epilepsy. Then we will reduce the dose, de-escalate the dose to 15 milligram per kg per day, and we have to proceed for either biochemical confirmation of pyridoxine dependency or genetic confirmation of pyridoxine deficiency, that is anticutin gene mutation. In biochemical confirmation, we can go for urine, plasma, CSF for AASA, that is alpha amino adipic acid semialdehyde levels and pipercholic acid levels. But it is essential that we have to do a mutation study so that we can do genetic counseling and we can prevent in the next pregnancy, because all these disorders are autosomal recessive. And then once, if there is no response to pyridoxine trial, then we will be giving empirical biotin also, check whether and sending for the serum biotinase level and whether the child is improving with the biotin. Suppose there is a partial response to pyridoxine, we will be adding either pyridoxal phosphate and then folinic acid also. And then we may do CSF analysis with the corresponding blood sugar level to look for or to rule out GLUT1, that is glucose transporter deficiency. This is the protocol which we do follow, sir. And then we will be sending samples for TMS, urine organic acids, to rule out inborn errors of metabolism. Then, of course, some rare disorders, as then if everything is negative, then we will be thinking in terms of genetic causes, and we will be sending for genetic mutation studies. Probably the second one would have been diagnosed by that, I think so. If it's so, Ramakrishnan, or you have suspected from the biochemical test itself, this serine synthesis defect.
Serine synthesis from the metabolic workup only, madam. Because clinical exam actually confused the issue. The clinical exam result was AGS syndrome, madam. Then it's of variant of uncertain significance, and we both the parents, they were both negative, and clinically also they didn't have any features of AGS, madam. So I thought that is exam sequencing result is not significant.
Not significant. Okay, very nice.
I was looking for algorithm for people in the periphery who can't do all these tests to prevent, while these tests are being done, is an algorithm of this simple thing that can be started in children? Can you get a therapeutic result?
Yes.
If you wait for all these things, most of the children won't get it. I was looking for these are all biotin, all vitamins only. So why don't you make an algorithm for people in the periphery to use this until the tests are done or results come? This is like being referred to the fourth center, quaternary center. No, this is fine. This has been talked about for a long time. I wish Kumarasan was online. This we have been discussing for a very long time, Dr. Leena. What I'm asking for a practical, these treatments are not drugs. They are not levetiracetam. These, what you have discussed so far, are deficiencies. Can you not make an algorithm that can be used for people until they can find a diagnosis?
Yes, sir, definitely, sir.
So why don't you make an algorithm?
Okay, sir. Definitely, sir. We will do, sir.
To use in the periphery until you can do all these.
We get the reports of the metabolic tests. Yes, sir. Step 1, step 2, like that, we will do an algorithm, sir.
These are simple things. You start, then you can do the test. If they respond, then you don't do the test.
Yes, sir. Definitely,
put
sir.
Algorithm that people can follow periphery. We could not do these things in the Institute of Neurology when I was there. Can you imagine the difficulties? Even if you think it is, who's going to do all these tests for you? So create a practical algorithm. Okay, you got a case, clinical classification. Then you say you start these things, then we will do the test. Please.
Okay, sir. Definitely, sir. Definitely, sir. We will do,
Excellent.
sir. Thank you, sir.
Excellent, Ramakrishnan.
Thank you, sir. Thank you, sir.
One more word about this levetiracetam in children.
Yes, Megan, sir.
This is beyond doubt proved, sir. Levetiracetam is a drug which can be given even for neonatal seizure. So neonatal seizure slowly, because in less than 2 years, the use of valproate is doubtful. And hence, levetiracetam we started using, and it has been very effective, found very effective, and especially neonatal seizures. And hence, slowly, I think this will come into I think the study results will come out well, and levetiracetam will be one of the armamentarium for neonatal seizures.
The dosing is based on kilogram based body weight.
Yes, sir. Yes, sir. Yes, sir. Same 20 to 30 milligram per kilogram. Higher dose initially, and then you can loading dose, then followed by minimal dose.
Can we go further?
So we have finished, sir.
Finish?
It's for you to give your
Congratulations.
closing comments, sir.
In this COVID period, to maintain education was only the computer. Now we got practical cases and so much learning. I wish you had invited Kumaresan also for this.
I don't know whether he is awake at this point of time, sir.
Timing, yes, I just say about
Timing,
to say the timing is wrong. Yeah.
Yes.
No, but excellent, excellent, all of you. God bless you. Dr. Paul, will you please drop an algorithm
Yes, sir.
for people where this test cannot be done? It's a
Definitely, sir.
Poor country. These are not drugs. It's a, yeah. Are these tablets available, serine and all that, or difficult?
It
Yes,
can
sir.
be
They are available, sir.
available, sir.
Through Amazon. I think he got it through Amazon, sir.
Yes, sir. Yes, sir.
Great. Thank you so much. Have a lovely Sunday lab for you and enjoy yourself. Protect your family. Charity begins at home.
Compulsorily, we have to, sir. Can't go outside.
Huh?
Compulsorily, they
No,
have to
even
stay
if you can
inside.
go
We can't
out.
go outside, sir.
No, I'm saying in spite of, even if you're allowed to go out, you must protect your family first. Yourself, your family. Don't be a hero or a heroine. Yeah? Charity begins at home. God bless you all.
Thank
It
you,
was
sir.
lovely. What a Sunday.
Thank you,
What
sir.
a Sunday.
Thank you, sir.
This is a
Thank you very much,
Wednesday.
sir.
It's a Wednesday for Institute. Natarajan.
Thank you very much, sir. Thank you.
Thank you, sir. Thank you very much, sir.
Thank you, sir.
Thank you, everybody. Thank you.
Sir, you were about to say something, sir.
Natarajan, it reminds me of Wednesday in Institute.
Yes, sir. I understand, sir.
Beautiful.
Sir, next month it will be from Salem, sir. Two
Doesn't matter.
neurologists from Salem.
I'll be very happy to be there.
Yes,
Just
sir.
inform me.
Thank you, sir.
Yeah, thank you. God bless.
Thank you so much, sir. Thank you, sir.
Bye.
Thank you, sir. Thank you, Natarajan.
Thank you, Bala. Thank you,
sir.
Ram.
Thank you,
Thank
sir.
you,
All
Deepa.
of
Thank you, Meghandan.
Thank you, sir.
Vijayan.
Thank you.
All those who took part. Thank you, Vijayan.
Go and enjoy
UMS,
your Sunday.
UMS is not there, I think.
Enjoy
now.
your Sunday.
All of you, thank you so much. Thank you, Sun Pharma, for providing the platform.
Thank you, sir.
Thank you for the help.
Inform us.
Thank you, sir. Thank you very much, sir.
Thank you.